It's one of those diagnoses that sounds deceptively simple on paper. Your body doesn't make enough cortisol. Okay, take a pill, problem solved, right? But then you start reading the fine print. You realize this isn't just about feeling a little tired. It's about your blood pressure, your salt balance, your brain fog, and how your body handles everything from a common cold to a stressful day at work. Suddenly, low cortisol feels like a massive understatement. Today, we are unpacking the My Adrenal Life annual members-only report on adrenal insufficiency. We're going to bridge the gap between the medical definition and the biological reality of living without a stress response system. I'm Jake.
And I'm Rachel. And you are absolutely right, Jake. The gap between take this pill and actually understanding the mechanics of adrenal insufficiency, or AI, is huge. The report we're looking at today really emphasizes that this is a multi-system issue. It's not just a hormone problem, it's a survival mechanism problem.
Let's start with that survival mechanism. The report leads with a pretty strong hook. Cortisol is essential for life. I think most people hear cortisol and think belly fat or stress management like it's a bad thing we want to get rid of.
Exactly. Pop culture has demonized cortisol as this villain that makes us anxious and gain weight. But biologically, you literally cannot survive without it. The report clarifies that cortisol is the ignition key for your body's stress response. And I don't just mean emotional stress like a deadline. I mean physiological stress. If you get an infection, if you break a bone, if your blood pressure drops, cortisol is the hormone that rallies your resources to keep you alive. In AI, that rally never happens.
So if I am healthy and I get the flu, my cortisol spikes to help me cope. If someone with AI gets the flu, nothing?
Right. Their tank is empty. The report calls this a lost reserve. A healthy body automatically ramps up cortisol production during illness, injury, or surgery. Someone with AI doesn't have that automatic gear shifter. They're stuck in neutral while climbing a steep hill. That's why the report mentions that ordinary illnesses can become medically significant events.
Okay, so that's the broad stroke, but the report distinguishes between different types of AI: primary, secondary, tertiary. Is this just academic hair splitting, or does it actually change the patient experience?
It changes everything, particularly regarding salt and hydration. Let's break it down. Primary adrenal insufficiency, often called Addison's disease, means the adrenal glands themselves, those little triangular hats sitting on top of your kidneys, are damaged. Usually it's autoimmune destruction.
Like the body attacking its own hardware.
Precisely. And because the factory itself is broken, you lose more than just cortisol. You often lose aldosterone. This is the crucial distinction the report makes. Aldosterone is the hormone that tells your kidneys, hold on to salt, get rid of potassium.
So without aldosterone, you're just flushing salt?
Yes, and water goes with it. That leads to low blood pressure, dizziness, and salt cravings. The report notes that this fluid and salt balance problem is specific to primary AI. Now compare that to secondary or tertiary AI.
Which are brain problems?
Essentially, in secondary AI, the pituitary gland in the brain isn't sending the signal, the ACTH hormone, to the adrenals. The adrenals work fine, but nobody is telling them to produce cortisol. Crucially, though, the signal for aldosterone comes from a different system, the kidneys, not the pituitary. So in secondary AI, aldosterone is usually preserved.
That explains why two people with adrenal insufficiency can look so different. One might be chugging pickle juice and fainting if they stand up too fast because they have Addison's, and the other might have normal blood pressure but severe fatigue because they have secondary AI.
Spot on. And the report highlights a third category that's becoming much more common: steroid-induced AI. This happens when someone takes prednisone or high-dose steroids for asthma or arthritis for a long time. The brain sees all that synthetic steroid and says, "Oh, we have plenty," and stops signaling the adrenals. The machinery goes dormant.
It's like the body forgets how to make its own fuel because you've been feeling the tank externally for so long.
That's a great analogy. And waking that machinery up takes time, sometimes months or years. The report specifically warns against assuming steroid-induced AI is mild. It carries the same risk of crisis if you stop the medication suddenly.
Let's pivot to the symptoms, because the list in this report is exhaustive. It mentions the brain, heart, kidneys, gut. It feels like a whole body breakdown.
It is, because cortisol receptors are on almost every cell in the body. The report breaks this down system by system. Take the brain, for instance. We see mentions of brain fog, slowed thinking, and reduced stress tolerance. This isn't just being tired, it's a metabolic failure of the brain to process stimulation.
The cardiovascular section caught my eye, too. Vascular tone. I usually think of muscle tone like biceps, not blood vessels.
Think of your blood vessels like elastic tubes. Cortisol helps keep them tight enough to maintain pressure. Without it, the vessels relax too much. Gravity takes over. You stand up, the blood pools in your legs, and boom, dizziness or fainting. That's a classic sign.
And then there's the gut. Nausea, vomiting, diarrhea. This seems like a cruel irony because if you need to take oral medication to stay alive, but your stomach is rejecting everything.
You've identified the most dangerous loop in AI management. The report explicitly states, vomiting and severe diarrhea deserve special attention. If you can't keep your pills down, your cortisol drops. If your cortisol drops, you get more nauseous and vomit more. It's a spiral that leads directly to adrenal crisis.
Let's talk about that term, adrenal crisis. It sounds dramatic, but what is biologically happening?
It is dramatic. It's a medical emergency. The NIDDK defines it as acute failure of the cortisol stress response. Your blood pressure bottoms out, your electrolytes go haywire, sodium drops, potassium spikes, you can lose consciousness. It's basically shock. The body shuts down because it cannot cope with the biological demand placed on it.
And the triggers aren't always car accidents or major surgeries. The report lists fever, vomiting, and dehydration.
Right. A stomach bug that a healthy person sleeps off in 24 hours can kill someone with AI if they don't have an emergency plan. That's why the report emphasizes the emergency injection. The NIDDK and NICE guidelines both say patients need an injectable form of hydrocortisone. It's essentially an EpiPen for cortisol. If you're vomiting and can't swallow pills, you have to inject the hormone to bypass the gut.
I want to touch on the diagnostic journey. The report mentions diagnosis pitfalls. Why is this so hard to catch? I mean, if it's life-threatening, you'd think doctors would be looking for it constantly.
The problem is that the early symptoms are incredibly vague. Fatigue, weight loss, low blood pressure, nausea. That sounds like everything. It sounds like depression. It sounds like anxiety. It sounds like IBS. The report notes that symptoms fluctuate. You might feel okay one day and terrible the next, which leads doctors to think it's lifestyle or psychological.
And then there's the pigmentation clue. The report talks about hyperpigmentation in skin folds. That seems so specific.
It is, and it's a huge giveaway for primary AI, Addison's. When the brain is screaming at the adrenals to work, it pumps out massive amounts of ACTH. ACTH is structurally very similar to the hormone that stimulates melanin, so people get dark tans, even in winter. They get dark gums, dark scars. But, and here is the pitfall, this only happens in primary AI. If you have secondary AI, you might be pale.
So a doctor looking for a tan patient might miss the pale patient who is just as sick.
Exactly.
Let's move to treatment. We talked about replacing the hormones, but the report has this really interesting section called What Treatment Does and Does Not Replace. It says medicine doesn't perfectly recreate normal physiology. What's missing?
Nuance. A healthy body pulses cortisol in a rhythm, high in the morning, tapering off at night. It also micro-adjusts every minute based on stress. Did you get cut off in traffic? Microspike. Did you skip lunch? Microspike. A pill is static. You take it at 8 a.m. and maybe 2 p.m. You get a lump sum of hormone, not a dynamic flow. Patients often describe feeling brittle. They're alive and safe, but they don't feel resilient.
Brittle is a powerful word. It implies that you can break easily.
And physically, they can. That's why the report discusses sick day rules. This is a critical concept. If you have AI, you have to do manually what the body usually does automatically. If you have a fever, you have to double your dose. If you have surgery, the anesthesiologist has to hang a bag of IV hydrocortisone. You have to be your own adrenal gland.
That sounds exhausting. The mental load of managing the condition seems almost as heavy as the condition itself.
It is. The section on living with adrenal insufficiency really touches on this. It says, life asks for more preparation, more body awareness. You can't just spontaneously go on a hike in 90-degree heat without planning your hydration and salt intake. You can't just ignore a stomach ache. You have to be hyper-vigilant.
Which brings us to the social aspect. The report mentions that newly diagnosed people are often told to avoid stress. But as you said earlier, we're talking about physiological stress, not just, I have a deadline.
Yes, and that's a huge source of confusion. Family members might say, oh, don't worry about the laundry, it's too stressful for you. But doing laundry is fine. What's dangerous is getting the flu or having a root canal. The report clarifies that emotional stress matters, but physical trauma, illness, injury, surgery is what triggers the biological crisis.
I was struck by the appendix, questions nobody tells you to ask. There was one about libido and androgens. We focus so much on cortisol and salt, we forget about the other hormones.
The adrenal glands produce DHEA, an androgen precursor. In primary AI, that's gone too. For women especially, this can mean zero libido, dry skin, and a lack of mental drive. The Endocrine Society notes that DHEA replacement is sometimes an option, but it's often overlooked because it's not essential for life, like cortisol, but it is essential for quality of life.
That distinction, essential for life versus essential for quality of life, seems to be the friction point for many patients.
It really is. The goal of medical treatment is usually keep the patient alive. The goal of the patient is, I want to feel like myself again. There's often a gap there.
Let's talk about emergency preparedness. The report mentions that family and friends need to know how to use the injection kit. That's a big ask. Hey, come over for dinner, and by the way, if I pass out, please stab me in the thigh with this needle.
It is a big ask, but it's non-negotiable. When someone is in full-blown adrenal crisis, they are often confused, lethargic, or unconscious. They cannot inject themselves. The NIDDK advice is clear. Wear a medical alert bracelet and train your circle. It's like CPR. You hope you never have to do it, but you need to know how.
The report also covers travel. Time zones must be a nightmare if your medication is based on circadian rhythms.
It's complicated math. If you fly from New York to Tokyo, your body clock is upside down. You have to adjust your medication schedule to match the new time zone, or you'll be awake all night and crashing all day. Plus, you need to carry extra meds in your carry-on in case of lost luggage and a letter for customs explaining the needles. It's logistical gymnastics.
We've covered a lot of the heavy stuff. Is there a hopeful angle here? The report does mention that people can live full lives.
Absolutely. NICE guidance specifically says patients should be reassured that they can live full, active lives. We have athletes with Addison's disease. We have CEOs. President John F. Kennedy had Addison's disease, though it was kept quiet at the time. With proper management, meaning taking your meds, understanding sick day rules, and carrying emergency gear, you can do almost anything. The constraint is the planning, not the capability.
So it's about shifting from a passive taking a pill mindset to an active managing a system mindset.
That is the perfect way to put it. You become the manager of your own endocrine system.
Before we wrap up, I want to circle back to the sick day rules because I feel like that's the most practical takeaway for anyone listening who might be newly diagnosed. Can you walk us through a scenario? Say, I wake up, I have AI, and I have a fever of 101.
Okay, scenario, fever of 101. Rule 1, don't panic, but act immediately.
Standard guidance is often the double dose rule. You immediately double your daily glucocorticoid intake until the fever breaks. You also push fluids aggressively, preferably with electrolytes, not just plain water, especially if you have primary AI. If the fever spikes higher, or you start vomiting, you go to the ER or use your injection. You do not wait and see.
That wait-and-see instinct is what gets people in trouble.
It is dangerous in AI. In a healthy person, wait and see is fine. In AI, time is tissue. The quicker you replace the cortisol, the faster you stabilize.
This report really drives home that adrenal insufficiency is an invisible disability. You don't look sick until you are very, very sick.
And that invisibility can be isolating. People might see you hiking one day and then unable to get out of bed the next because you have a minor cold. It's hard for friends and employers to understand. That's why resources like this report are so vital. They give patients the language to explain their reality to the people around them.
Rachel, what's the one thing you think is missing from the standard conversation about AI that this report actually nailed?
The distinction between types. I think lumping everyone into one bucket causes so much confusion about salt and blood pressure. The fact that this report explicitly separates primary from secondary/tertiary AI is a service to patients. It validates why one person craves salt and another doesn't. It stops the comparison game.
It really highlights that personalized medicine isn't just a buzzword, it's a necessity here. You can't treat a pituitary patient exactly like an adrenal patient, even if the pill bottle looks the same.
Exactly. And asking the right questions, like the ones in the appendix, empowers the patient to get that personalized care. Asking, do I have aldosterone deficiency, changes the treatment plan.
We've gone deep into the biology, the crisis management, and the daily grind of adrenal insufficiency. It's clear that while the adrenal glands are small, their impact is massive. It's a condition that demands respect, but with that respect, it's manageable.
It is. Knowledge really is safety in this case. The more you understand the mechanism, the less scary the crisis becomes, because you have a plan.
If you know someone navigating this diagnosis, or if you just found this deep dive into human physiology fascinating, send this episode their way.